Welcome to the Caregiver Relief Podcast, where we support, empower, and inform family caregivers navigating the challenges of caring for aging loved ones. I'm your host, Diane Carbo. This episode is sponsored by myvitalvault.net, your all-in-one life organizer for aging adults and caregivers. It's designed to help you securely store your essential legal, medical, and emergency information in one easy-to-access place. Because when a crisis hits, being prepared can make all the difference. Join our Caregiver Relief community, a warm, welcoming space where you can connect with other caregivers, ask questions, share stories, and find support from people who truly understand. Visit community.caregiverrelief.com to join now, because caregiving is one of the hardest and most meaningful things you'll ever do, and no one should have to do it alone. And if this episode speaks to you, please take a moment to like, share, or comment. Every click helps us reach more caregivers who need encouragement, resources, and hope. And today we're tackling a topic that is often misunderstood but critically important: ECT, Electroconvulsive Therapy, especially in older adults living with treatment-resistant depression. Joining me today is Dr. Joshua Bess, a nationally respected psychiatrist and medical director of Seattle NTC, one of the busiest ECT and interventional west of the Mississippi. Dr. Bess has extensive experience in treating seniors with depression that doesn't respond to medication. And he's here to clear up myths, explain modern ECT, and offer hope to caregivers who feel like they're running out of options. Dr. Bess, thank you so much for joining me here today. I really appreciate you and addressing this difficult topic.
Thank you for inviting me, Diane.
I see you've had an interesting path. You've gone from rural Indiana to interventional psychiatry in Seattle. What drew you to focus on ECT and working with seniors?
What drew me to psychiatry was seeing people who weren't treated very nicely, or at least were upset or anxious about talking to doctors or talking to healthcare professionals. Yeah. Coming out of a small town, the only doctor I knew was the family doctor. So when I went to medical school, I thought I would be a family doctor or maybe a pediatrician. And my first psychiatry rotation really changed that 180 degrees. And I found out that folks not only were exceedingly in a lot of need for interventions and for treatment, but also just human kindness. And I happened at the time, and hopefully still, to be good at human kindness. And I was able to make connections with people that other classmates of mine found it difficult to make. So that's how I jumped over into psychiatry. In my training program, the first 6 months of my training program was at the Veterans Affairs Hospital in Ann Arbor, Michigan. And that was the ECT center for the whole VISN, the region within the VA that referred patients to that hospital. And we got an earlier exposure to ECT with a beloved mentor of mine. And it was just off from there. I really enjoyed seeing people get better so quickly, and for people who had been long suffering to feel a lot better in any way was great. And so I just continued from there and chose my path to hang out with the ECT people.
There's still a lot of fear and misunderstanding about ECT. Can you explain what ECT is today and how it differs from the outdated images people may have?
Of course, yeah. ECT, for both good and bad, has been around for a long time. So we have more experience with ECT than really almost certainly any other psychiatric treatment. And it predates almost all the psychiatric medications. It predates all the other interventional technological things that have come about in the last 15 to 20 years. But then it also means it has a bit of a troubled history as well. Mm-hmm. And it today is a very safe, effective, relatively non-invasive, although there is an IV line and things like that. Treatment for depression, for other serious issues that we can talk about if you'd like. But for the people going through ECT, it's scary because it's like any other medical procedure. You're going to be asleep. You're not in control of what's happening for that period of time. There are potential side effects, which we'll talk about. And until you do something the first time, it's a scary thing. And what's remarkable is that people who have a series of treatments, because it comes in a series usually, by the second or third treatment, or at least by the second or third week, it's just a rote thing for them. It's a inconvenience and something that they don't necessarily look forward to, except for feeling better. But it really is routine. And I'll tell you, there are clinics in the US, unfortunately not ours, where a family member or loved one can observe the procedure. And there's a family-centered ECT movement. And my colleagues who work in those clinics tell me after the first or second time, they don't really bother. They go get a cup of coffee because, okay, I've seen it. It's pretty mundane, actually, with all the hype and all the stigma and negative history. These days, it's very routine. But yes, it used to be done without general anesthesia and without muscle relaxation or muscle paralytic. So that's where you get the scene from the cuckoo's nest. The other issue is the forcing people to do it, also related to the cuckoo's nest. And so those two big weights of history that we're carrying still are no longer the case. Informed consent is exceedingly important. And since the 60s, really, it's been standard of care, at least in the West, to use both a paralytic to make the muscles not move and a general anesthetic to put the person to sleep so that they're okay with their muscles not moving. And that's basically it. It hasn't changed a whole lot since then, except for some finesse and revising of protocols and procedures and frequencies. And there's lots of research ongoing still. But the biggest change has been that. And since then, it's a very safe, relatively, I say non-invasive, relatively straightforward procedure.
I suffer from treatment-resistant depression. I've had it all my life. I tried every single antidepressant there was. They worked for a little bit, and then they stopped working. And I'm actually excited. I actually go to a ketamine clinic. And I will tell you right now, I have a family, a mother-daughter team, that the daughter brings her mom to the ketamine. And the mom takes the daughter to her ECT.
Yep.
And the daughter is in her 50s, late 40s, early 50s. And she says, ketamine's not for me. I want ECT. And when I heard that, because of my visions of when I was in nursing school with ECT, I was shocked. But they talked about it like it was just, like you said, it's just nothing bad or big about and terrible about it. So I really it enlightened me. That's why I was so excited about talking to you today, because we really do need to dispel. People need to find what works for them.
Right.
And they have to get over their fears of the unknown. So that's what we're going to do here today, I hope.
Yeah.
So why is ECT particularly effective for older adults suffering from severe depression or other psychiatric illnesses?
Like a lot of things in medicine, including psychiatry, but even in other fields of medicine, the real answer is we don't know. We observe that it is, and we observe that this thing helps, and that it especially helps people and older people in the later stages of life. There are lots of theories about why it might be more effective in older people, but we don't really know for sure. I always am a little bit tickled by that. There are many things in life that you can say work better when you're older.
I can attest to that.
I'm looking forward to maybe if I'm in that position in the future, that I'll have this to fall back on. And my family certainly knows that's what I want if needed. So there are theories that involve the type of depression that people have when they're older. The neurophysiology does change over time, and ECT works exquisitely well in older people who have what's called psychotic depression, where you have some sort of false beliefs or some sort of experiences that aren't real, like a hallucination or a worry that your family is trying to steal your money or that people are trying to harm you in some way. And that's that type of depression, along with some of the other features that happen in advanced age, They're just exquisitely responsive to ECT. And so there's a theory that the type of depression is just more responsive. The brain over time, as it's developing, gets into certain ruts and certain habits. And maybe by the time we get to our 60s and 70s and 80s, yes, we have some hard-wired habits, but we're also in a place where we're wiser, we're more at peace with things sometimes. We're not quite as bullheaded, let's say. And so that's how I think about it too.
Irish girl. I've got the bullheaded is still there.
But because it is a fascinating question, why that is. And when I'm counseling people about their options, I will, if someone's in front of me, this just happened this past week. If someone's in front of me and they have some of those features, some of those characteristics that we see, since medicine is pattern recognition and we know that things that go together tell us a story, I'll be very open with them and say, look, this is by far the best chance you have. We could do other things first. I'm not saying we can't, and if you would like to, we should, but to give you the best chance, this is what I recommend. There's that. We do have to be extra careful because people do have other medical problems more often as we get older. There is a little bit of a balance there. We're looking more closely at cardiovascular function, neurologic function, respiratory illness, things that you can accumulate over the decades, right? And so while it does work so well in that population, we're extra careful medically, but also that's just testament to how safe it is. If you have people who are in their 90s or even 100 years old getting this procedure on some sort of an intermittent or repetitive basis, like it must be safe.
Oh, it must, absolutely. Many caregivers worried about memory loss with ECT. Can you tell us about the safety profile of modern ECT, especially for seniors?
Yeah, this is really important. And this is the avenue that anti-ECT or anti-psychiatry groups or people will very often try to exploit. And just a quick aside, like what other treatment in all of medicine has a group of people who are focused on opposing it, right?
Yeah.
But there are memory problems that can happen with ECT. And that's a very important part of the informed consent process.
Okay.
And what is tricky is the person who's a potentially good candidate for ECT is also vulnerable. If you're severely depressed, if you have worries that bad things are going to happen, even if that's not realistic, or that someone's trying to hurt you, if you are so depressed that you're not eating and you have poor nutrition or you're not sleeping well, that makes you more vulnerable to anything. Yeah. And then we're trying to have an informed consent discussion about the risks and the potential benefits. But setting that aside for a second, there really are three main thinking or memory things that can happen. Okay. And how I describe it to people is the first one happens to everybody. You're confused right afterward. Your brain just had a seizure. You've had anesthesia. You're waking up from a procedure. You're in a strange place, although it gets to be familiar after a couple of treatments with strange people who then get to be friends.
Yes,
and so
exactly.
You're waking up and you're 15, 20 minutes it takes for you to be reoriented, right? Mm-hmm. And so that happens to everybody, no matter what their pre-ECT cognitive function was or what kind of side effects they might have. And so that's just to be expected. The second is difficulty forming new memories. So when your brain has a seizure, I think of this as short-term memory, or like the back in the old days where we had computer disks. So not the hard drive, but the disk that you would put in, or maybe the CD-ROM. So it's temporary, but longer term than just here in the moment. Forming new memories is really hard because the way our memory works, we have an experience, it hangs out for a bit, and then it gets put into more longer term memory. While it's getting processed, if your brain has a seizure, it's disrupted. That process is disrupted. And so during the course of treatment, if you're getting 2 or 3 treatments a week over several weeks, you will have a hard time remembering things that have happened during that time, maybe a little bit before. Often it's mundane things. Did I have dinner with my friend last night? They mentioned it this morning, but I don't remember. Or did I send that check for whatever I needed to pay? Or did that person visit me? Some of those things, like those day-to-day life things we just take for granted that we'll remember. What did I eat yesterday? So we really counsel people not to make any big decisions during a course of treatment, certainly not to sign any legal documents or do anything like that. Again, the vulnerability, right? But so that forming new memories, what we call anterograde amnesia, kind of that, as we're going through life. Now, once the ECT is done, or you're coming less often, at least, maybe you're doing a maintenance course less often, that pretty much goes away. Maybe the day of treatment is foggy, but you don't have ongoing trouble forming new memories. Okay. So that's number 2. Number 3 is what people really are afraid of and get very upset by, and is a serious situation that you have to make sure that people understand going in. And that's forgetting things from the past. And one of the difficulties is it's very hard to study. I don't know what's in your brain. I can give you a test before and after, right? But I don't know what's in your brain from years and years ago, and what your life experiences have been, and how you've experienced the world in different places at different times. And so it's one of those things where you don't know you've lost it until you've lost it, right?
Yes.
And so people do get really worried about that. And it does happen. And we have to be honest about that. It's not common. It's not as common as it is often portrayed to be. But there are people who have what we call retrograde autobiographical amnesia, forgetting some things from their past. By and large, as best we can study it, these are usually things that are not personal, or not very, they're not woven into the fabric necessarily of your history, of your life. They may be events, they may be things that are somewhat tangentially related to you. You're not going to forget who people are. You're not going to forget your huge events in your life. And you may forget a trip that you took, or you may forget fine details of a trip that you took. And reminders can help, and talking it over with people can help. But yes, there is this kind of Swiss cheese that can happen where you do forget some of those things. So those are the 3 types of memory impairment that we talk about. A very recent study also brought up a 4th dimension that's important, which is how you feel about all of that, the subjective memory impairment. So I can give you a test, but the test doesn't, the test can tell us maybe if you're actually able to pass the test, but it still doesn't have anything to do with how you feel about your memory. And there are 25% or so of people 6 months after they're done with ECT will have subjectively a feeling that their memory is not as good as it was for things in the past. And again, mostly those, yes, things that happened in your past, but weren't intensely personal to you. And so that's how we've been talking with people about it.
That's fascinating. As an aging senior myself at 72, I have foggy memories of trips and things that I've took or have taken it in one time or another. To me, it wouldn't feel like it was anything unusual.
Well, and a funny thing is that people are different too. So
yes.
my wife is the family historian, and she remembers so many developmental things and so many of those little moments with the kids. And not to get the impression that I was some sort of absent father, but my memory doesn't work that way. I have pastiches or broad brush strokes. And sure, I have,
yes.
Yeah, and now with social media, or everybody has a camera in their pocket, it does help. But those are still reminders. Those are reminders that I need to oh, that's what happened. And some people just are more either chronological or detail oriented or more photographic. So there are differences in people to start with. Exactly. And so that's one thing that we always consider. Something else to keep in mind is cognitive function in some ways declines for everybody as we age. But we do sometimes think about there are differences if someone is a professor versus, say, a truck driver or longshoreman, right? So I talk with people from all walks of life. Yep. And I say, if you use your brain for a living, you might notice, you might have a better sense or a more precise or fine-tuned sense of when you're having some even relatively minor difficulties. Whereas if you don't use your brain for a living every day, it's not that you're not smart, you just don't use it like that every day. Exactly. You might not notice until it's more severe, until there's more impairment. And so that's something also that we have to take into account. So we want to counsel the people who want to take some time off their job as a teacher or a nurse or a professional, have ECT, their depression gets better, go back to their job. We try to be really forthright with them about these potential side effects and how that can, the vast majority of them end up going back to work, but it can be a process.
So when do you recommend ECT as a treatment option? And what has typically already been tried?
That's been really cool, a cool evolution over even my lifetime, my career. So when I was finishing training, so I graduated residency in 2008. If I were in the treatment-resistant depression clinic at University of Michigan, it was basically a question of ECT or not, right? Vagus nerve stimulators had been approved a couple years previous. That's a side topic. They were around, but not widely adopted. We would sometimes, there were medications that people hadn't tried, and because they have more side effects, a little bit older, so we would sometimes recommend that. We would always make sure that you were either in a good situation with psychotherapy or they had a very good trial of psychotherapy. But really, that was the question. That's what we had. The IV ketamine was really just in its infancy, and TMS was being studied. It got its FDA approval in 2008, but it took a long time to be widely adopted as well. Yeah. So yeah, that's what we talked about. Now, if you fast forward almost 20 years later, I have a whole clinic and a whole staff of providers and staff here who, depending on how you count it, are able to offer 5 or 6 or 7 different things to somebody who comes in and says, I've tried a bunch of medications and they haven't helped me. And so really it is a nuanced, detailed discussion about what to do first, or what order to do things in, or what characteristics your situation has that makes me think that this might be the most helpful for you. A lot of times it comes down to logistics, for example. So with respect to ECT, I think about it in 2 categories. There are people who walk into my office or who I see them in the hospital, and I think to myself, like, this person needs ECT. Okay. So an older person with that psychotic type depression that we talked about, or someone who's not eating very well, someone with what we call catatonia or catatonic features to their situation, to their mood disorder, or from another cause. Those are people where most of the time we will at least give serious consideration to doing ECT first. Right. And there may be other roadblocks, there may be other problems that, that we have to figure out, but that's going to be at the top of the list. The second category of people who get ECT are the people who have tried everything, quote unquote. Yeah. And so you might do a course of TMS, transcranial magnetic stimulation, or you might have, like the person you were talking about, ketamine is not for me. Either I tried it and it was not for me, or I don't like the idea of it, whatever, or I can't afford it. That's a thing. Exactly. And so that's on the Monopoly board here, you've been around and you've passed go a couple of times. And so then we're talking about ECT as a thing that isn't the last resort. I'm always very careful to not talk about it as this is it. This is the final station on the train line. But it's the thing that is the most invasive and does carry the most baggage, let's say, and is a big deal as far as getting to the hospital and going through other things, but also still has the best chance of working. So either you fit the pattern, you fit the characteristics of somebody we know is going to be a good responder to ECT, or you've tried several other things, which fortunately now include other interventions, not just medication, but those haven't done the trick. And so then we consider ECT.
So what does a typical course of ECT look like, and how long does it last, and how quickly do patients tend to respond?
So in the US or in North America, generally we do ECT 3 days a week for somebody who is in a acute or intensive or what we call an index course. It's their first time. And in many places in Europe, it'll be twice a week. It works the same. It just takes a little bit longer, but usually 3 times a week for 3 to 4 weeks. It is very purposely wishy-washy and vague because we track the response very closely, like daily, right? Now, it's excellent to be able to offer a treatment in psychiatry where you track the response daily because it starts to help in a matter of days, right? But the average, the number that people throw around is 12. Some patients and their families will get a little bit attached to that number. So we're careful to say, you might need more, you might need less, but 12 is a good round number. A month off of work or needing to arrange transportation or something for a month. And so generally that's how it plays out. I'm a education co-chair for the ISEN, which is the International ECT organization. And one of the things that the organization has always been trying to do and continues to try to do is really like study and sift out like what's best practices and how should we approach certain situations, because there is a wide variety of approaches even within ECT. But usually we'll start with a protocol, and if somebody's not feeling better by the end of the second week, by around the sixth treatment, we'll switch up the protocol, we'll do the ECT a little differently and continue, and then we'll keep assessing whether they're responding. I've had people who felt something after the first treatment. That's not common, but it happens. But definitely by the third, fourth, fifth treatment, if they're going to be a solid, very straightforward responder, we'll start to get some sort of signal. That doesn't mean that we stop. If it's not there by that time, we keep going. By the 10th or 12th treatment, if we have no signal at all, if things are just really stuck, we sit down and assess, is there something we need to do differently? Did we miss something here? Is this not the condition that we thought it was? The cases I remember from my career are the ones where we did a course of ECT and got nothing, right? And they didn't respond at all. And then down the road, we figured out, oh, it was something else. It wasn't what we thought. It was mimicking a severe depression, that sort of thing. So that's a general course. After your first course of ECT, you have a choice to just stop, be done with ECT after that 12 or 14 or something. I'm feeling better. I want to go back to work. I want to go back to my life, or I want to go back to Arizona, whatever. Yeah. And we're very willing to say, okay, great. We're here if you need us. We hope we never see you again. Wink. If we're here, if you need something. So then that clock starts. And if you are doing some sort of maintenance medication, you probably have about a 2/3 chance that you'll make it 6 months to a year without any kind of relapse. If you don't do anything, if you don't do maintenance medication or maintenance ECT, it's about 50-50. Okay. And I say 6 months to a year because some studies are 6 months, some studies are a year, and somewhere in there, if you make it to a year, you're doing pretty well. If you do both maintenance ECT and medication, that's even better. So certainly by the second time somebody's had a full course of ECT, or the third time they've had a full course of ECT because they've relapsed, we'll recommend maintenance ECT, which is in the weeds as far as how we do that. But it's basically less often, once a month or something like that.
That was going to be my next question. Yeah, what does maintenance look like?
Open-ended, right? Okay. So once a month, for some people forever. Yes. For some people, a couple years. For some people, 6 months. And then we let them stop and see how things go. But if you do maintenance and if you do medication, you have maybe it's a 25%, give or take, relapse rate at a year. But 2 years, 3 years, it's the rule rather than the exception. The mood disorders are episodic. It's going to come back at some point. And it's sad to see, even though we always explain that to people, but then they come back to see me 5 or 6 years later. And it's like, oh, I thought I was okay. You were okay for 6 years, and we're going to make you okay again. But yes, we have to deal with this right now.
Yeah. People don't understand that your body's always changing, and maintenance is not a bad thing.
Yeah. It's hard. I'm always trying to think of analogies because I'm an analogy thinker. And so I want to try to explain it to other people with analogies. One analogy, which I really just think isn't that useful, is dialysis, because dialysis is pretty horrible. Yeah. But it's something that you need, and you just go do it, and then you go on with your day. Yeah. There are some dermatologic conditions where you have to go get laser treatment once a week or once a month. So somewhere between those two is maintenance ECT. And there are people who, I've been in this job for going on 12 years, and there are people who I met as maintenance ECT patients who I'm still seeing. For them, the once a month or once every 6 weeks, one treatment, couple hours at the hospital is more than worth it to otherwise be able to not think about or not fear having that severe relapse.
I am at a maintenance for my ketamine right now, and I go every 6 to 8 weeks, and my biggest fear is that I'm going to go back to the way I was feeling, and because I don't take any other medication right now, I have not had to do that. But yes, and I'm very faithful about being aware of how I'm feeling and what I'm doing, and check the calendar, go, yep, it's time to go again.
Yep.
Yeah. And I think that as we get to older, we also know our bodies better. And if you're aware of what's going on, especially with depression, it's really challenging. Can you notice you don't want to eat anymore, or you just don't want to get out of bed? And there are so many things. And I've seen people in severe depression, and it is amazing to me, the results I've seen with ECT, and that was decades ago. But that's the reason why I was so interested in talking to you. When this woman was saying that she preferred the ECT to ketamine, I went, really?
Yeah.
That shocked me. Everybody has their needs, but the fact that she knew what she wanted and knew what worked for her was really important.
Yeah.
And also, she was supportive that her mom preferred the ketamine.
Yeah.
That was really important. So how do you determine if a senior is medically appropriate for ECT?
So we partner with either their primary care physician, or if they're in the hospital, there's usually like a internist or hospitalist team that will consult on the psychiatric unit. And really the questions are, it's like any procedure or surgery or operation. The term that gets thrown around, which is a little bit misleading, is clearance, right? So it's preoperative clearance. And primary care physicians know what to do with that. Even though they're not giving us permission, they're not clearing it, they're telling us that things are optimized, right?
Yes.
But that just takes a lot longer to explain. So basically, you can have any number of conditions or illnesses or things that you're being treated for. As long as your treatment is optimized, that you're doing the best you can, and you're physically healthy enough to endure what the physiologic things that are going to happen during ECT. At the very beginning of first of all, anesthesia in general. So can you be healthy enough for anesthesia? There's this, when we first give the ECT stimulus, there's an impulse that will slow down your heart. Very temporary, but young people especially will slow way down. And then when the seizure starts, your heart speeds up and your blood pressure goes up. Is your heart healthy enough basically for exercise, like for a brief slow down and then exercise? Okay. So someone who has untreated coronary artery disease, or who isn't optimally managed with their, say, congestive heart failure, like that needs to be sorted out first. So cardiac, also along with that blood pressure increase, intracranial pressure goes up because the blood is going up and the brain's being very active. So things in your brain that are already causing problems, like maybe don't want to also add that. Something like an aneurysm, let's say, that's just being monitored. We'll really consider that as a risk, and we'll want to really make sure that we're managing their blood pressure exceedingly carefully. Because if that little aneurysm or that little blood vessel goes way up and it pops, that's bad, right? And then respiratory function. So we don't use a breathing tube. You don't get intubated for ECT. It's just a mask that the anesthesiologist uses to help you breathe, because it's 3 or 4 or 5 minutes that you're out. Right. If your respiratory function is already compromised. And this was the huge thing during COVID, aside from people being contagious, right, which was a problem, and we had to manage that. If somebody was recovering from COVID, we really have to make sure that their respiratory function is pretty much back to baseline, or at least 90% better, just because of that stress that happens during the treatment. So those are the big things. I had a mentor or supervisor that I really love who would quip that the only absolute contraindication is power failure, right? And that's not quite true. There are some things that certain types of tumor, or like I said, an aneurysm that's not stable, where we would say that needs to be dealt with first. Not that we can't do ECT down the road. A recent stroke is another example.
Okay. People
who have had a stroke several months before and it's stable, and even if they still have deficits, you can have ECT. And depression after a stroke is very common.
I'm just going to say that, yes.
Yeah, 100%. And ECT can be effective for that. But we're going to wait until things are stable and that the tissue is not still molding and changing, and it's not still an acute thing that's being dealt with. So those are the medical things that we're mostly looking at.
What advice do you have for family caregivers who are nervous about ECT, but are watching a loved one suffer with debilitating depression or other things like paranoia or wanting to harm somebody? How do you address that?
It's really hard to see somebody suffer like that. But that said, ECT, it is anxiety provoking. Like we were talking about earlier, it's like any procedure. It's not something you do for fun. Let's put it that way. And so I try to lay out for them how things are very likely to improve, and that a delusion or paranoia or even just the thought that they can't eat for whatever reason, that they're too full, even though they haven't eaten all day. That's their brain sort of playing a trick on them, right? That's their brain misfiring in some way. And we can apply a treatment to the brain that will turn that around, right? It doesn't come without risks. There are problems that could arise. They might have, like we said, memory side effects of various kinds. And it's a lot. It's a hassle, transportation-wise. We have people who take 2 bridges and a ferry to get here, and it's an all-day affair. But it can be really worth it for so many people. One thing I forgot to mention when we were talking about memory is that studies have also shown that if you test people before they have the ECT, because depression itself can affect memory, and then you test them 2 days after, it's worse. Then if you test them 15 days after, it's better than when we started. And there's the acute effect of the ECT, but in general, the memory gets better. So their thinking improves, is more clear. They're more able to take care of themselves. They may be talking about a parent or a sibling or a loved one who lives independently, but there's a question about whether they're going to be able to if the illness continues.
Yes.
We can return people to living independently, like we've already talked about, returning to work, returning to doing the things they love. So that's how I talk about it with them. And then really it's a matter of fielding questions or addressing their specific concerns. Some people say, oh yeah, I know the memory thing is a thing, but my memory's bad anyway. Or mom can't ever remember where she put her glasses. That doesn't bother us. But we're concerned about this, or we're worried, we heard about that. And so you can really meet them where they are as far as those concerns as well.
Oh, I'm one of the seniors that goes looking for my glasses. They're on my top of my head.
Yeah, exactly.
That's a senior moment yes.
Exactly. Yeah.
Now, is ECT typically covered by Medicare or insurance for older adults?
Yeah, almost universally.
Good.
I find it, I used to find it humorous. It's definitely odd. It's been around for so long, that it really has been grandfathered or grandmothered in to the system. And when new things are coming out like TMS or Spravato, esketamine nasal spray, we have to jump through all kinds of hoops. And there's all these like elaborate policies, and we're checking boxes. And I have a staff of people here to do that. Yes. And then we get to the point where the person needs ECT, or if they come in needing ECT, and my administrative staff says, oh yeah, no, we just have to document that they need it. But we don't need authorization, and we don't need permission. And so especially early on with the other things that were getting to be more prevalent and more popular, I would tell people like, yeah, I can take an ECT right now and I don't have to get permission from anybody, but I have to get permission to like give you this other medication, and it's going to take a week to get that sorted. So it's almost always covered. There are guardrails, and you want to make sure that you have the right diagnosis and that you're not doing it outside of accepted parameters and accepted practice guidelines and all of that. But one of the common worries that people have when they're in that depressive kind of anxious ruminating state is about their money or their finances. And so it can be really challenging to try to convince somebody that, oh yeah, ECT is covered, it's no problem, when they think they're going to get a large hospital bill. Yeah. And our system has also primed them for getting a large hospital bill. Absolutely. So it's an interesting kind of little cul-de-sac that sometimes we get stuck in, where we're trying to work with that person to understand that we've done this a lot and it'll be covered.
And that's nice to hear, because our medical delivery system, the insurance, Medicare is moving to a cost sharing. And the things we need, like skilled care, maybe $200 to $500 a day copay from some insurance company. So to hear that this is covered is a good thing. And I hope that continues, because we lack so much support for our mental health patients in this country. So totally, yes, Dr. Bess, what gives you hope about the future of interventional psychiatry for seniors, and what message would you give to leave with caregivers today?
We've been talking a lot about ECT, and that's my passion, one of my passions, but one that I think is important to highlight. Like I mentioned, there's still ongoing research in all kinds of different parameters of ECT, and ways to deliver the ECT that helps mitigate memory side effects or mitigate other things that are problematic with the ECT. And so there are studies going on and people looking into theoretical brain modeling and all kinds of different things where is there a way that we can deliver this and have it be less invasive or less intrusive into the person's life? Other ways to give the brain a seizure besides electricity has been looked at for a long time and is making its way through the scientific process. Do we even need the seizure in the first place? There's studies out there of subconvulsive ECT. Is it the electricity or is it the seizure? So there's that whole thing. And even so, setting all of that aside, there's so much promise with TMS and with these ketamine compounds. When TMS first came out, many of the private insurances who were at least covering it had an age cap of 65 because the prevailing wisdom was that it didn't work in older people. And it took people treating older people and getting good results that were just as good to break through that. And now that doesn't exist anymore. It's accepted that it works at any age up. Those things happen with science and with medical research. The hot thing right now are psychedelics, right? So that's getting a lot of press. And our clinic is involved in several research studies there. And, the hope that I have is that people are just going to have more options.
Yeah.
And options that have been vetted and studied and that I can, with a high degree of confidence, say, not only is this safe, but has a good chance of helping. We never have 100%, right? Heart surgery isn't 100%, aspirin's not 100%, right? But it's something that is reasonably safe given the situation. And there's this chance that it will help you, which is much, much better than trying your seventh antidepressant or this other therapy that hasn't been really well vetted. So that's what gives me hope that there's, now that I'm in the stage of my career where I know many of the people who are doing this work and who are doing the science and who are running the clinics and just know how committed they are and how they're not in it just to fool people, right? They're not selling snake oil. That gives me hope.
Dr. Bess, I want to thank you so much for spending time with me today. I know you're really busy in your clinic. How can people reach out to you?
The easiest way is to go to our website, which is Seattle NTC, Nancy Travis Charlie, SeattleNTC.com. Okay. And so that has then an array of options for what treatments we offer, how to get in touch with us, an email address, a phone number, all the things that you might want.
And we will have that at the bottom of the page that we create for you as well after this podcast so that my families can reach out or the seniors can reach out.
Absolutely. And we are plugged in, let's say. So if somebody's in a different state, there are resources that we can point them to or people that we know who can help them out.
Great. To my family caregivers out there, you are the most important part of the family caregiving equation. Without you, it all falls apart. So please learn to be gentle with yourself. Practice self-care every day because you are worth it.